No problem. And I just want to go over some funding announcement, just to say that this webinar is supported by a cooperative agreement through CDC, and none of the contents are the responsibility of the authors. They are the responsibility of the authors and do not necessarily represent official views of CDC or the Department of Health and Human Services.
Okay.
There you go, Tim. Please take it away.
All right. Hello from the great state of Washington. On behalf of the APHL Hemoglobinopathy Work Group, I would like to welcome you to part one of a two-part webinar series on alpha thalassemia. My name is Tim Davis, Chair of the Hemoglobinopathy Work Group and lead microbiologist at the Washington State Newborn Screening Program. Our work group was convened in 2013 through the National Center on Birth Defects and Developmental Disabilities, Division of Blood Disorders, the CDC, and APHL to address issues around hemoglobinopathy testing and newborn screening. Whether your program uses isoelectric focusing, HPLC, or a combination of both for hemoglobin screening, we're all detecting alpha thalassemia through hemoglobin BARTs. The question is, how do we report it? Should we report it? And ultimately, how does this information help the newborns and families we serve? Through these webinars, we will explore globin chain expression and imbalance, the types of alpha thalassemias, and how reporting helps with diagnosis and treatment. We'll also look at examples of isoelectric focusing, hemoglobin constant spring, HPLC percentages and cutoffs, testing algorithms, and the current status of alpha thalassemia screening across the United States. Today's webinar focuses on the clinical aspects of alpha thalassemia. Our first speaker is Dr. Maria del Pilar Aganagua. Dr. Aganagua is the co-director and laboratory director of the Meharry Sickle Cell Center. She holds an adjunct faculty appointment at the Department of Medicine, Division of Hematology Oncology at Vanderbilt University. Her research interests are in sickle cell disease and women's health, and her clinical interests lie in the diagnosis of hemoglobin disorders, for which she is consulted nationally and internationally. She also directs the State of Tennessee Newborn Screening, Hemoglobinopathy Confirmatory and Reference Laboratory, housed at the Meharry Sickle Cell Center. We've also reserved time at the end of this presentation for questions. Welcome, Dr. Aganagua.
Please press *7 to unmute yourself.
Thank you, Tim. Greetings to everyone. I would like to start by defining hemoglobinopathies and thalassemias. First slide, please. Hemoglobinopathies are most common due to mutations in the globin genes, specifically in the coding regions that are going to change the normal amino acid sequence of the globin chain. And this produces hemoglobin variants. In the case of the thalassemias, we have deletional types and non-deletional types that are going to lead to a decreased availability of the particular globin chain that is being affected. And therefore, there will be an imbalance in the normal coordinated synthesis of the globin chain subunits that we see. These disorders originated in the tropics. However, due to worldwide migration, they can be found anywhere. Next slide. And it is estimated that about 5% of the world population are hemoglobin variant carriers. On this slide, we have the globin gene clusters. We have the alpha globin gene cluster on chromosome 16 and the beta globin gene cluster on chromosome 11. The way these genes lie on the genome are also the same way they are expressed during ontogeny. Next slide, please. Alpha thalassemia mutations are probably the most common mutations in the world. And most of the alpha thalassemia mutations are due to deletions in the alpha globin gene. But we also have less common non-deletional type alpha thal mutations leading to some hemoglobin variants that are going to give an alpha thal phenotype. There are at least 50 known deletions which involve both of the alpha globin genes in the affected chromosomes, and over 69 known types of non-deletional type alpha thalassemia mutations, but these are in general very rare. The two most common alpha-globin gene deletions are the 3.7 rightward and the 4.2 kilobase pairs leftward. And we can see this better on the next slide. In general, in the United States and in some states, we have 1 out of 15,000 births affected with alpha thalassemia. In African Americans, we have 1 out of 30 births that will carry an alpha-thal mutation and 1 out of 20 births that will carry a Southeast Asian mutation. Next slide, please. Most of these mutations are prevalent in people from Southeast Asia. On this figure, we have the deletional types. We have 7 out of the 8 most common alpha-thal deletional type mutations. So we can see the 3.7 and the 4.2, the Southeast Asian, the Mediterranean, and others. Next slide, please. This table, we have the clinical forms of alpha thalassemia. When we have 4 functional alpha-globin genes, we have the normal phenotype. And our red blood cell indices are normal, and we have known hemoglobin abnormalities. When we have 1 alpha-globin gene deleted, this condition is called silent carrier or Alphathal2 heterozygote. Basically, there are no clinical symptoms, and the red blood cell indices may be slightly affected. And we will see at birth a small amount of bark hemoglobin, 1 to 3%, which will disappear as the baby grows up and develops. When we have 2 alpha-globin genes deleted, we can have them 2 in the same chromosome or 1 in each chromosome. In this case, this is called Alphathal2 homozygote or Alphathal trait, and we have mild anemia, microcytosis. Hemoglobin is 11 to 13 grams, MCV 65 to 75 femtoliters, MCH 24 to 27 picograms. And at birth, we will have a little bit more hemoglobin bars, 3 to 6%, which will disappear as the baby grows up. In the case of the Alphathal1 heterozygote, which is also an Alphathal trait, we have similar clinical features and same red blood cell index. When we have 3 alpha-globin genes deleted, this condition is called Alphathal intermedia or hemoglobin H disease. Here, we have a variety of clinical features. It could go from moderate to severe anemia. Hemoglobin 7 to 11 grams, MCV 55 to 65 femtoliters, MCH 20 to 24 picograms. And newborn BARS at birth is going to vary from 5 to 30%, even though in my experience, when I see 20 to 30%, I strongly suspect hemoglobin H disease. And then hemoglobin H after 1 year of age is going to vary as low as 3%, as high as 20%. And then when we have the 4 alpha-globin genes deleted, this condition is called Bart's hydrospetalis or homozygous alpha thalassemia. The clinical features are usually fetal death with hydrospetalis. This condition is incompatible with life. And hemoglobin is less than 7. The cells are bigger, 100 to 110 femtoliters. And MCH is less than 22.9 picograms. And hemoglobin bars usually is 99, 100%. Next slide, please. As we have deletional types of alpha thalassemia, we also have non-deletional types of alpha thalassemia, usually involving hemoglobin variants. For example, hemoglobin constant spring, which has a termination codon mutation, therefore it produces an extended alpha-globin chain, or hemoglobin PAC-C, or other highly unstable hemoglobins like hemoglobin agrinio, Swan-Do, Quon-Z, or PAC-NAMPO. Next slide, please. In alpha thalassemia, we will have a decreased availability of alpha-globin chains, which is going to lead to accumulation of beta chains and gamma chains. The beta force will form hemoglobin H, and the gamma chains will form hemoglobin bars. There is also a reduced amount of normal adult hemoglobin, hemoglobin A. Now, hemoglobin H is going to produce the red blood cells to be more sensitive to strong oxidant compounds, resulting in hemolysis. This can be worsened by oxidant drugs, mothballs, or infection. And in general, the red blood cells are going to be hypochromic and microcytic. Next slide, please. Hemoglobin H disease, you can have hemoglobin H disease with 3 alpha-globin gene deletions or two alpha globin gene deletions plus a hemoglobin variant like, for example, hemoglobin constant spring. So in general, we will see hemolysis and ineffective erythropoiesis. The co-inheritance with other globin gene defects affect the hemoglobin severity, and it is believed, and it is seen that hemoglobin H, hemoglobin constant spring, has a more severe course. And about 50% of these cases usually are due to hemoglobin PAC-C, hemoglobin H plus hemoglobin PAC-C, also an unstable variant. Next slide, please. How do we diagnose hemoglobin H disease? Well, first we have amount of bars at birth, the presence of hemoglobin H itself. Hemoglobin A2 is generally low, but you know in the newborn hemoglobin A2 is low anyway. Total low hemoglobin, low MCV, low NCH, sometimes hemoglobin constant spring or other variants, and in general most patients are from Southeast Asian origin. Next slide, please. Clinical symptoms, moderate anemia and microcytosis, also jaundice, hepatosplenomegaly, and some infants may have poor growth and development. And sometimes you're going to see facial and skeletal abnormalities, as well as gallstones, leg ulcers, iron overload due to the ineffective erythropoiesis. Next slide, please. What is the definite diagnosis? You can diagnose at the newborn stage hemoglobin H disease, usually by high-performance liquid chromatography, where you can determine the amounts of bulk hemoglobins and also the presence of hemoglobin H. More than 25% hemoglobin bars is suggestive of H disease at birth. Then you need to have a confirmatory test, which is going to involve other more sophisticated techniques, perhaps selective focusing and even DNA analysis. These babies need to be referred to the pediatric hematologist for diagnosis. If the baby has been transfused before the newborn screening sample was taken, then please repeat the newborn screening sample after 90 days post-transfusion. Next slide, please. Other recommended tests are selective focusing electrophoresis, hemoglobin electrophoresis. If you have a baby with hemoglobin H disease, please test the siblings as well and provide counseling to the parents. Next slide. In general, the alpha-thal trace will show no specific characteristics on electrophoresis, HPLC, or even capillary electrophoresis, except for a marginal reduction in hemoglobin A2 expression. This reduction is more prominent when you have hemoglobin H disease or when the genes are dysfunctional for the alpha-globin genes. HPLC and capillary electrophoresis can detect alpha-thal in newborns because of the different levels of hemoglobin bars and the presence of hemoglobin H. Next slide, please. Here we have, this is a 3-month-old infant, and this is an IEF electrophoresis, and you can see where the arrow is pinpointing. You can see some fast migrating bands. You can see 3. The very first one is hemoglobin H. The next one is BART, and the others, and you can see others that they are very faint, they are multimers of beta and gamma globin chains. Next slide, please. This is a 3-year-old Southeast Asian infant, and here you can see on the HPLC, this is an ultra 2 primals HPLC. You can see BART hemoglobin, very fast eluting. Then you can see some fetal and hemoglobin H, about 7%. Next slide, please. This is an adult. It's a 23-year-old adult from Southeast Asia that the sample was analyzed Mehari, and we can see hemoglobin A and a very retarded mobility or elution hemoglobin at the end of the chromatogram. On the left, we have the BioRad variant 2 chromatogram, and on the right, we have the Primos Ultra 2 chromatogram. If you see on the right 2 arrows, the first arrow is pinpointing to BART hemoglobin, and the second arrow pinpoints to hemoglobin H, which co-elutes with hemoglobin A1C. So we decided to send this for DNA analysis. Next slide, please. And DNA analysis reveal hemoglobin H plus hemoglobin constant spring. And please note that the S at the top should be after the C. It's constant spring, CS. And DNA analysis reveal alpha constant spring alpha / Southeast Asian deletion. So this patient had hemoglobin H plus hemoglobin constant spring disease. Next slide, please. This is a case of BART hydrospetalis. This baby was seen last year, it was born with 99% hemoglobin bars. Next slide, please. So early diagnosis is important because of the wide spectrum in clinical manifestations and severity. You have to regularly monitor hemoglobin levels to monitor the patient's anemia, as well as growth and development, and assess chronic hemolysis complications, assess possibilities of infection, and overall healthcare monitoring and proper immunization. Next slide, please. Do not alarm the parents if you have not done a confirmatory testing for hemoglobin H disease, and provide education to the parents to understand the importance of following up with their PCP for additional testing and referral to a pediatric hematologist. Next slide, please. Regular visits to pediatric hematologists, and parents should really understand hemoglobin H disease, that it is a chronic disease, and it will require monitoring of hemoglobin levels, growth, development. Provide a list of support services such as local health departments and early intervention service providers. Genetic counseling and education for the parents and the families is strongly recommended. And for more information, please look at newsteps.org. Thank you very much.
Thank you, Dr. Aganagua. Our second speaker is Dr. Michael Bender. Dr. Bender has a broad background in and long-term commitment to both basic science and clinical medicine, with them dovetailing in the study of globin genes and disorders thereof. Integrated with this basic science work has been a long-term commitment to the care and education of patients with hemoglobinopathies. He has run a program for children with hemoglobinopathies in Washington State for over 15 years and has had funding from the Health Resources and Services Administration and the Washington State Department of Health to develop a collaborative to improve clinical care and provide community outreach for families affected by sickle cell. He provides consultation to the Washington State Newborn Screening Program on hemoglobinopathies and is a Northwest resource for community physicians. Welcome, Dr. Bender.
Well, thank you so much for this opportunity, Tim, and thank you so much, Karina Yusuf, for your patience in helping me get set up with this talk. To start off, I want to compare the issues of newborn screening for alpha thalassemia with that of sickle cell disease and some of the metabolic diseases. Unlike sickle cell and the metabolic diseases, in alpha thal, it's not about preventing a dramatic acute phenotype like brain damage and death. In sickle cell disease, it's important to keep in mind that newborn screening reduced the morbidity and mortality of sepsis even without prophylactic penicillin. The key in this case was that early diagnosis and education of providers and families on detecting fever and how to respond greatly improved outcomes. Plus, it allowed genetic counseling, leading to more informed decision making. In alpha thalassemia, while not as dramatic, it's really about avoiding a family odyssey of children not thriving, recurrent medical testing, misdiagnoses, treating the wrong condition with contraindicated or potentially dangerous interventions, avoiding tensions with the medical providers, and minimizing long-term complications. And I'll go into all of that. So there's much less impact, but potentially reach far more children and families. How do we do this? Well, first by tapping into the current infrastructure of diagnostics. It's about family education and safety teaching and provider awareness and education, in part because there's a huge educational void in terms of diagnostics and management here. And then along with this is the side benefits of allowing genetic counseling and avoiding hydropic pregnancies. So my approach today is start by reviewing the last major review of looking at hemoglobin H as a core target for newborn screening. This was done in 2010, and this is the front page from the report, and it's available on the link below. And then to discuss other benefits of newborn screening. Part is in terms of its effect in terms of alpha thalassemia trait, and then genetic counseling. So when it was reviewed in 2010, they obviously decided not to do universal testing, and this is from their summary in terms of what some of their concerns were. As it states, the committee felt that they had not heard compelling evidence to suggest hemoglobin H belongs on the screening panel, that there's no compelling clinical need presented. Therefore, more evidence was needed. So what were they looking for? Well, one was what proportion of children would benefit from condition-specific treatment. Where do we stand? Well, there's some more data, but not a lot. They asked what the variation in prevalence across the United States is, and there's more data for that. They asked, does early identification improve health of identified children? And I'll go over this, and there's some data for that. They wanted to know about what the target is. I'm not going to go over that. And then they wanted to talk about infrastructure and what the expectations are for newborn screening labs. And Tim Davis will cover some of that, and I'll cover some of that as well. So in the report, they really wanted to address multiple key questions about bringing testing to hemoglobin H disease, about the condition, screening tests, diagnostics, treatment, economics, and other. And in part 2 of the series, Tim Davis is going to cover diagnostic tests and screening tests. So I'm really going to focus on the key questions about the condition, the treatment, and the economics. And I'll come back to these systematically later, so don't worry about reading these now. So, the first talk was a beautiful review of Alphathal, but I'm going to do a very focused, repeat of some of that. Alpha thalassemia, it's really about chain imbalance, not about decreased expression. It's what would the unpaired hemoglobin chains do. In terms of screening, hemoglobin H, it's made out of a tetramer of the adult hemoglobin. This is too unstable to be seen on gels, and so it's not useful for adult testing. In contrast, in the newborn period, hemoglobin FARX, a tetramer of the gamma chain, is unstable, but it's still stable enough to be seen on gels. So it provides an easy test to newborns, thus providing a window of opportunity in the newborn period for an easy, cheap diagnostic test. Unlike beta thalassemia, usually the whole gene's deleted, and it's quantitative, that the level of hemoglobin FARX correlates with the numbers of genes deleted. In contrast, hemoglobin constant spring, as mentioned, is not as common as the deletion form of hemoglobin H, but it's the most common form of it, and it's much more severe, and thus was called out. It's due to a point mutation that was brought up, and it's quite unstable, and usually it's seen on gels. So why is hemoglobin H constant spring so much worse than hemoglobin H? Well, this is a map of the alpha gene loci. There's the embryonic gene and 2 adult alpha genes. And upstream of the genes is a super enhancer that activates the genes. And the 2 genes compete for the activity of this enhancer. So alpha 2 is closer, it competes better, so you get more expression than alpha 1. So normally in humans, alpha 2 is expressed more highly. So what happens when you delete alpha 2? Well, there's no competition with alpha 2, so alpha 1 gets all the attention, so there's an upregulation, and you get more alpha 1 expression than in normals. So that's key. In alpha gene deletions, you delete one gene, the expression of the other goes up. So in hemoglobin H, what happens if it's a deletional form, you get upregulation and more alpha 1 than you would normally get. What happens in hemoglobin constant spring? Why is it worse or more severe? Well, here you're not deleting constant spring. It's still present. So you still compete with that enhancer regulatory region. So you do not get upregulation of alpha 1. So you end up making less alpha chains than in other forms of hemoglobin H. So as a result, the gene's present, you don't make the useful protein, you get competition, you don't get the upregulation. So what are the concerns in hemoglobin H? And again, this was reviewed before, but I'll go over it again in brief. Some of it is about decreased growth, and I'll show some data about height and weight and bone mass, ineffective erythropoiesis, which can lead to a large spleen and iron overload. But the most common thing is the chronic anemia, and occasionally the anemia drops and gets even more severe. Potentially this requires transfusion, but most tolerate the anemia on a daily basis just fine. What are the risks for dropping from this baseline anemia and potentially needing a transfusion? Often viral or other infections can suppress making red blood cells so you can drop. Inflammation or oxidative damage, which can be from some foods, some medications, or concomitant G6PD deficiency. So there's also one of the problems with hemoglobin H is there's a lack of awareness of the chronic anemia and its etiology, and that there's what kind of evaluations are needed. As in beta thal, you can get some iron overload secondary to the ineffective erythropoiesis, even if you don't get any transfusions. It's progressive, and when people are older, they may need chelation. It's slower than beta thalassemia, but it still occurs. And if you have hemoglobin H with constant spring or other non-deletion forms, all these things are just more serious. So as I mentioned, there's knowledge gaps. So this is from the summary last time in 2010 when they looked at how best to treat hemoglobin H. And as you see, there's a paucity of quality literature out there. So what's the natural history of hemoglobin H if you diagnose it early? Well, kids get started on folic acid to help make red cells. They get monitored with CBCs, looking at reticulocytes, watching iron status, looking at accumulation. That's the main lab and medicine part. The biggest part is family education. It's awareness that the child has anemia and how to manage it. How to avoid oxidant exposures like sulfa drugs, fava beans, mothballs. How to monitor it, which is mostly looking for the signs and symptoms of worsening anemia, such as being pale, having fatigue, change in their color, decreased perfusion, capillary refill, less energy, just being more fussy. It's about families learning when to be seen and having blood work done. Because if they notice these things, it's important to have blood work done to see if you're more anemic than usual. And it's about avoiding iron unless you're proven to be deficient, not to give it just because you have anemia. In terms of provider education, it's the same as for families. Many general practitioners, family medicine, pediatricians, primary caregivers don't know much about hemoglobin H. So it's critical providers know about how to diagnose and care for hemoglobin H. It's common, as I'll get into, to give people with anemia, inappropriately give them iron or to transfuse. It's important to teach them that this isn't a generic microcytic anemia, that iron overload occurs even without giving iron, and that iron is contraindicated unless it's documented. So this is a beautiful article from several groups, including the group, mostly the group in Oakland from 2011. And it's comparing regular deletional hemoglobin H with hemoglobin H with constant spring. And through this, the open triangles are hemoglobin H and the closed are hemoglobin H constant spring. And if you look at growth, the top panel is weight. You see hemoglobin H constant spring is much more severe than hemoglobin H, the deletional form. If you look at height, the same thing. The orange line shows changes by age 5, because for newborn screening, you really care about things that affect children under 5 years of age. So really, there's a dramatic difference in height and weight for those with hemoglobin H constant spring below age 5. The top panel on the right is the hemoglobin, which again you see is lower, and the bottom 2 panels just show that hemoglobin H constant spring. You have more reticulocytes, which means you're working much harder to make blood, and your bilirubin's higher, showing that you're hemolyzing, you're breaking down red blood cells more readily. This is the big one. This is those with those children that were transfused. And if you look at hemoglobin H, the deletional form, very few get transfused before age 5. In contrast, by age 5, about 40% of children with hemoglobin H constant spring have required a transfusion. So pretty dramatic. So overall, about 5% of all forms of hemoglobin H need a transfusion before 5 years of age. So one of the big questions is, how do you know someone needs a transfusion? How does this come about? Well, if you know you have hemoglobin H and people are monitoring for anemia, it's easy to tell, okay? If you don't do that, they often present with a profound, potentially life-threatening anemia. So if you're diagnosed with hemoglobin H and you're not diagnosed with newborn screening, what happens? Well, there's not any good data for how these children present, because most of them haven't been diagnosed, or many of them haven't. But my own experience and many hematologists' experience is it's a referral for an anemia not responsive to iron. Now, this brings us to general pediatrics. If you look at the American Association of Pediatrics, for all newborns, all infants, they recommend a hemoglobin screening at 12 months of age. The main reason they're doing this is to detect iron deficiency and iron deficiency anemia, which are very important because iron deficiency in infants can lead to neurodevelopmental problems and have a neurodevelopmental impact. So you want to pick it up early. So every 12-month-old, regardless of hemoglobin status, should be tested at 12 months. Unfortunately, this is a real mess. First of all, it's usually screened for cost reasons by a screening hemoglobin, where the sensitivity and specificity aren't great. But it's also a complex screening algorithm the AAP recommends, where they also want to take into account a history for the social economic status, heritage of the family, and diet history. So it's a lot of work. Depending on the results, they recommend either treating with iron or testing and treating. So again, complexity, and then follow up to show correction. But one of the big problems, which I'll show next, is that this is often not followed and correction is not documented. That there's a big discordance between what's recommended and what's done. So this was a large study of the general pediatric population, looking at almost 5,000 children who were screened, at about 12 months of age for iron deficiency anemia. And depending on where, there's a wide range that screened positive, or depending on how you screen, between 1.5 and 14.5%. Thus, a large number of infants are involved here. The key things are, of those that were found to be anemic, less than 25% of those underwent a repeat. So there's not, within 6 months. So there is not good follow-up in general in the study. Moreover, only about 11-12% were shown to have a documented corrected. So a large number of infants are impacted. There's infrequent follow-up testing. It's rare to show documentation, and often people get iron and there's no follow-up. So how many of these kids have hemoglobin H or thalassemia trait? we don't know, and this is where I feel the odyssey begins, that infants are diagnosed as having anemia, but then what happens? So how do you quantitate the importance of what's going on here? And I think there's several ways to look at it. So one is the scenario where the infant, an infant or a child or an adult comes to medical attention, and then they get put on iron for iron deficiency, even though they don't need it. They're anemic because they've got hemoglobin H, not because of iron deficiency. And I'll tell you, if we start talking about it, if you start asking people, most people have stories. They know of people that got put on iron, and yeah, they keep getting more iron, and intermittently they're on iron all their life. Why is this? Do they have a hemoglobinopathy? Are they truly iron deficient? People don't know. So what happens in real life? Infants don't respond to iron therapy if they've got hemoglobin H. They've got anemia because they've got a hemoglobinopathy. So they're given iron again. Often there's a follow-up CBC, but not other diagnostics. Providers often get frustrated with the parents. Often you get accusations that, oh, they're not complying, they're not giving the iron, they're not giving it appropriately. But meanwhile, if they've got hemoglobin H, they're getting iron inappropriately. Often there's no follow-up, and children just float out there. Another scenario is someone develops a profound anemia. In this case, they can be transfused, but if it's hemoglobin H, often they have a low baseline anemia all the time and they're fine with it, and so sometimes they're inappropriately transfused. Or sometimes, because families aren't educated as when to come in, they're showing up with this profound anemia much later than ideal when kids are dangerously ill. Another scenario is someone's diagnosed with chronic anemia. They don't really evaluate why, and some kids end up on chronic transfusions, which is inappropriate. Less common, because of the splenomegaly and anemia, some children have their spleens removed empirically, which is not necessary here. And again, there's often tensions with healthcare in terms of how people are following up and following guidelines. What really happens in terms of how often any of these scenarios occur, it's not known, it just isn't studied. So what are the problems if hemoglobin H is diagnosed late in life as opposed to in a newborn? Well, there's delays, potential delays in seeking care, and the sequelae of living with a chronic anemia, potentially presenting with life-threatening anemias. The growth delays in height and weight I showed, sometimes chronic fatigue and decreased energy. There's the odyssey of misdiagnosis and at times inappropriate treatment. It's common to have multiple evaluations, appointments, labs, recurrent courses of iron that may be worsening iron overload, which aren't always necessary. If someone has hemoglobin H, a lot of that isn't needed. Can lead to the unnecessary splenectomy, conflict with providers, those inappropriate transfusions, whether once in a while or chronic, and those transfusions are time, stress, the financial costs, and potential risks of transfusion. And in addition, you're not doing anything about the potential genetic risk of the child or the parents of having other children with hemoglobin H or hydropic pregnancies. So going back to the key questions that the panel asked last time, what's the prevalence of deletional and non-deletional hemoglobin H disease? Well, it's tough because it's not routinely screened for or tracked in the United States. So there's a lack of data. It's more tough, it's even more difficult to report out hemoglobin H constant spring because it's not always seen on gels. And as far as I know, only California and Washington State screen for it. So because there's not great national data, I'm just going to go over the Washington State data, which I obtained from Tim Davis, and then also talks about some of the California data. So this is Washington State data for a 10-year period. And First, if you look at hemoglobin H, it just goes over the number of cases per year. The big thing is it works out to about 6.3 cases per 100,000 infants screened. In contrast, hemoglobin H constant spring, which is more severe, there's a 3-year period where there wasn't screening, but it occurs at about 10% as frequently as hemoglobin H. In contrast, I'll come back to this later, alpha-thal trait is far more common, about 40 to 50 times more common. If you look at who's at risk, as was brought up in the last talk, it's mostly in people of Asian descent, but with changes in social habits, there's a lot more ethnic mixing. So as a result, for the year pointed out here, while there's 4 self-identified as Asian, there's, half that amount as other or unknown. So increasingly, there's people of mixed race with it. In discussion with Dr. Ash Lal, who runs a thalassemia program in Oakland, he shared that the California experience is quite similar in terms of the numbers and percentages. It's just the numbers are much higher because the state's so much larger. In addition, he thinks that there's about 10 hydropic pregnancies that are dangerous. I mean, it's fetal demise plus dangerous for the mom each year. So in theory, what states are most highly affected? Well, it's currently most related to the percentage of Asians in the state, which is wide-ranging. So this is a map of the percent of Asian Americans in each state, which ranges from about 1% to 15% in California and 57% in Hawaii. So now coming back to the key questions. What's the natural history, including the spectrum and severity of deletional, non-deletional HbF8s during the first 5 years? Well, much of this I discussed above, and there's data lacking to know exactly what's going on and how many are actually being diagnosed. There's a wide range of severity of disease, but if diagnosed at birth and hemoglobin H constant spring, about 40% require transfusions before 5 years of age. If not diagnosed at birth, again, we don't have good data. It's this odyssey of, being diagnosed with anemia and not sure what happens after that. Potential iron therapy, transfusions, as I mentioned, and the tension with the healthcare system. In terms of treatment, does early identification improve the health of identified children, and what treatment methods are used? Well, how does one quantify the benefit here? Early diagnosis allows the education, starting folic acid, screening to transfuse when needed and avoid unnecessary transfusions. It leads to avoiding the inappropriate or repetitive diagnostics and treatment with iron transfusions, and it allows that opportunity for genetic counseling and avoiding hydropic pregnancies. What's the relationship? One of the sort of moving down the key questions, what's the relationship between treatment outcomes and the timing of treatment? It's not clear. And a lot of this is you must account for the quality of life and the impact of the family, which isn't documented and it's hard to quantify. What harms are associated with the delay? And how does inappropriate iron supplementation affect health outcomes? Well, delays lead to the living with anemia, the potential need for receiving emergent transfusions that could be avoided. This odyssey of misdiagnosis and inappropriate transfusion, and having a more rapid iron accumulation. But there's not data in terms of how rapid and what that does down the road. What are the potential harms or risks associated with treatment? Well, there are no real risks above that of the standard risks associated with transfusion. But here, at least the transfusions are being done therapeutically with a high benefit to risk ratio. What are the economics? What are the costs associated with it? Well, it's relatively cheap in terms of the testing because it's tapping into the current mandated pipeline. What's the cost effectiveness? It's not known, but the cost of receiving appropriate care is quite low, and you're saving money from avoiding the direct costs of the inappropriate diagnostics and treatment. What are the costs associated with the diagnosis and the failure to diagnose in the pre-symptomatic period? Well, it's much more expensive to diagnose hemoglobin H disease at an older age because you don't have that advantage of having hemoglobin parts. And again, there's those inappropriate tests that happen on the way to definitive diagnosis. What's the availability of treatment and what are the costs? Well, education is cheap. Folate transfusions are all readily available. The key is that newborn screening leads to very efficient access to optimal care as opposed to families stumbling through the medical system before a definitive diagnosis and appropriate treatment. Education, folate are cheap. And transfusion costs are highly variable, but if they're not diagnosed and they're transfused emergently, acute therapy and care is much more expensive. So finally, I want to come at this from a different approach. There's been a lot of talk about screening in terms of screening for hemoglobin H disease. So what about alpha-thal trait? So as brought up in the first talk, often there's a low normal or mildly abnormal hemoglobin and a low normal or mildly abnormal MCV. Children with alpha-thal trait are often confused with having iron deficiency anemia. They're often not diagnosed. They're often given iron inappropriately. Often there's the same issue of these diagnostic delays, not getting the appropriate testing, and repeated courses of iron, allegations of non-compliance and tension with medical providers. And while not nearly as severe as hemoglobin H, it's about 30 to 70 times more common than hemoglobin H. And it's diagnosed with the same newborn screening testing as hemoglobin H disease. So, a side benefit of reporting out hemoglobin H is you could also report out alpha-thal trait, which is what we do in this state, allowing for genetic counseling for hemoglobin H disease and hydroxyspitalis. So in Washington State, this is a summary of diagnoses. In the red box there are hemoglobin H disease, and you see in this year is only 7. But then if you look at those with various versions of alpha-thal trait, it's far more. And it covers a wide range of ethnic background. So I propose that reading out on alpha-thal trait in addition to hemoglobin H would not be any additional testing costs, or at least for this initial screen. In terms of report outs, in Washington State, it's sending out a letter only. It could include educational information on hemoglobin and iron screening, both for the families and the providers, along with guidelines for when to refer for genetic counseling. I think it would have a widespread, albeit mild, impact. There'd be more cost of iron screening, but this screening cost would be indicated anyway, and it would lead to, I feel, less unnecessary treatment with iron and associated follow-up. And finally, of note, this is only going to pick up alpha-thal trait, not beta-thal trait. And with that, I want to thank you for your time and open to questions.
Thank you, Dr. Bender. So during this question and answer session, you can press *7 to unmute and ask questions over the phone, or you can type your questions in the chat box.
Hi, Tim. This is Karima. I do have a question in the chat box, and it's for Dr. Bender. It says, you spoke of a hemoglobin constant spring and the ability to be observed on gels. Can a pattern for a constant spring be seen on HPLC? And if so, does it have the same retention time as hemoglobin BART?
Why don't I defer to Tim, because he's far more of an expert on this than myself.
Yeah, we've never seen it on HPLC. So I've heard that when they're older, you can see it, but in newborns, we don't see it on HPLC.
Great. Thank you. Does anybody have a question on the phone? You can press *7 to unmute yourself. Okay, we do have another question in the chat box, and it says, does alpha thalassemia trait reduce the severity of sickle cell disease? Do these patients have a spleen?
So alpha-thal trait, it's fascinating and complex, but alpha-thal trait in the presence of sickle cell disease decreases the severity of some complications and increases others.
Great, thank you. Any questions on the phone? Would somebody like to ask? If so,
this is Dr. Aguinaga. I have some comments regarding the first question.
Sure.
They have the same rotation time as hemoglobin BART for hemoglobin constant spring, and no, it does not. Hemoglobin BART is a fast eluting hemoglobin, so it's going to elute very early in your chromatogram, and hemoglobin constant spring elutes very far by hemoglobin C. And you can also tell by the percentage hemoglobin constant spring. Usually you can see 2%, 1% on the HPLC. And on isolated focusing electrophoresis, not in an infant, but in an older patient, you could see it is a very retarded band, very, very top of the gel, and it's a very heavy hemoglobin. So it's at the very top of the gel. Whereas BART is going to be on the other end of the gel, as fast running hemoglobin. Thank you.
Thank you, Dr. Aguinaga. So just to follow up to that question, what would be the recommended method for constant spring detection?
So, can I speak?
Of course.
This is Tim. So in Washington, what we do is when we get a hemoglobin H disease, we use genetic testing. So we do an actual mutation test. Sometimes it's seen on the gels and sometimes it's not. So it's not a highly reliable test. The best thing to do is to do real-time PCR and look for the mutation.
Great, thank you. I do have another question in the chat box. It asks, what is the difference between hemoglobin BART and hemoglobin H? The person was under the impression that hemoglobin BART is seen in newborn screening, whereas hemoglobin H is seen in older children.
Well, the difference is hemoglobin BART is a tetramer of gamma, so it's a gamma 4. Hemoglobin H is a tetramer of beta, it's a beta 4. And hemoglobin BART, you can see it at birth, and if you see the case that I presented of the adult that had hemoglobin H constant spring, you will still see some BARTs, about 7% in that adult. But hemoglobin BART levels are pretty much used to define different types of alpha-globin gene deletions. And when you have hemoglobin H, then you know you have hemoglobin H disease. Thank you.
Does anybody have a question on the phone? You can press *7 to unmute.
Hi, this is Tracy Bishop with the California program. Can you hear me?
Yes, we can.
Yeah, we had a question here for Washington. So they're calling out the alpha-thal trait?
Yes.
And are you providing any follow-up testing? Or just suggesting it?
So the recommendation in Washington is a recommended CBC and reticulate, and there's guidelines for monitoring for growth, and then contact information for genetic counseling or questions.
Okay. Just curious, because here in California we provide molecular testing for the possible, hemoglobin H disease that we call out. But I don't think if we thought about doing trait would be able to manage that for all those. So, interesting idea. Thank you.
Thank you. I do have a question in the chat box. It says, what are the molecular tools used in Washington for second-tier screening for hemoglobin H constant spring?
So in Washington, what we use is real-time PCR. It's allelic discrimination. It's basically a TACMAN assay. And if you'd like to contact me, I'd be happy to give you the sequence. And in the next presentation, I'm also going to talk about it as well. So.
Thank you. Tim, would you like to say a little bit about what's in the next presentation? Somebody asked in the chat box about what part 2 of the series will be.
Yeah, in part 2, it's going to be more of the newborn screening. So the first part was the clinical presentation, and now it's the newborn screening end. So we're going to talk about, there's a survey that we did. We'll talk about that. So we need to know what the current status of screening is in the country. We'll also talk about algorithms. We'll look at chain expression again. We'll also look at examples of percentages of BARTs. We'll look at isoelectric focusing. We'll look at HPLC as well. So there'll be a lot more coming.
Great. Thank you, Tim. Does anybody have a question on the phone? If you do, please press *7 to unmute your line. I do have a question in the chat box. It asks, is stem cell transplantation an option for hemoglobin H and hemoglobin H constant spring disease?
So absolutely, it's an option. Non-deletion hemoglobin H in general is not severe enough that I think most people would not think about transplanting it. Hemoglobin H with constant spring, it would really depend on the person's course. There are some patients that do great, never require transfusion. Those that might require chronic transfusions definitely would be discussed.
Great, thank you. Anybody else have any questions? You can press *7 to unmute, or you can type your question in the chat box. Okay, hearing none, Tim, would you like to close out the webinar, please?
Yep. A recording of this webinar will be archived on the APHL Newborn Screening Training webpage. You will receive a link to this page in your post-webinar follow-up email. PACE credits will also be awarded for attending this webinar. To receive PACE credits, you must complete the post-evaluation survey, which will appear at the post-webinar pop-up window and the follow-up email. If anyone has questions, you can contact Karima Yusuf. And thank you for joining us. Part 2 will be on June 29th at the same time. Take care.
Thank you.